Ladies and gentlemen, and this is the continuation of the first episode. This is episode 1B, the continuation. Trying to be aware of time. I want to give you the best content possible, share with you the experience and some of the knowledge that I'm learning and I want to share with you. Sharing knowledge is sharing the blessings, what we call in Arabic sharing the barakah. Barakah means blessings. So knowledge really is enlightening. And I want to let you guys know this. This is the structure of the first week. I had to literally, because I missed out maybe 4 lectures, I had to do what they call in our course a top-up task. I literally had to go through them, summarize them, and send them. That was a bit of an experience, but fortunately, I managed to get all of that done. So, week 1 of the course, getting to know people, meeting new people on, as I mentioned in the previous video, that literally on the 10th of February, Friday, I'm in there, I got accepted, I was told, Harshal, your situation has been resolved, sorted, come in and you can start the course. And I meet people from different, people from different variety of experience and people who've, been in, amazing people, absolutely amazing people. People who've really struggled and went through a lot to get to this course. So week 1, what are we learning? We're learning about the introduction to IAPT. We learned about the introduction to the PWP role. What does it stand for? What does the role entail? What does the role involve? What's our function? How do we operate? How do we work? And then we learned about the work itself, about diagnosis. How do we, what the issue of diagnosis? We learned about outcome measures, which are basically forms of how do we measure like what a person's feeling? How do we use certain questionnaires, such as the PHQ, the patient health questionnaire? How do we use other questionnaires? How can we use that to reflect and see whether that resonates or reflects what a person, a client or patient, whatever you want to call it. I personally prefer client, because to me, patient is more someone who's admitted. But anyway, it depends. So we want to see that reflects how they feel. Then we started to look at interpersonal skills. In the actual session, the skills that we have as a person and as a practitioner, those interpersonal skills about building the therapeutic rapport, building that therapeutic relationship, building that therapeutic alliance. What are the necessary skills that are needed? And also looking at risks, which is always seen in different parts of different professions. But when it comes to healthcare, risk is looking into, and it's seen from different perspectives, different eyes. When it comes to mental health, we're always looking at the risk of the person themselves, their own risk, their own safety, and the safety of others. Again, the safety of themselves and the safety of others, those that are around them. So let's start with honestly, when I was looking at the time and I was thinking about this whole 10 minutes thing, I'll be very frank with you. I felt like what I'm about to talk right now, I feel like 10 minutes is not enough. But what I'm trying to do is, as I said, I'm just trying to make sure I can upload it on to LinkedIn and on YouTube. But mainly YouTube, it can be as long as more than that. But with LinkedIn, it needs to be 10 minutes. So all I can say is maybe if I get another chance and I do get the time to explain deeper, maybe I can put that onto YouTube. But anyway, let me start. I just thought I'd give you a bit of an outline. And let's start with it right here. IAPT, the Improved Access for Psychological Therapies. Very brief into the story. I would say you can go into Google and look into it. But what I will say is this. Back in 2006 and 7, there was a particular politician who was also a professor. And he looked into Layard, if I remember his name. So he was, the issue at the time was that mental health did not get a lot of financial support. And there were so many people, millions of people experiencing. So you have psychosis, and then you have, let me split it to you like this. You have psychosis and you have neurosis. Psychosis is when a person goes from sanity to insanity. They've lost their sense of sanity. They've lost their sense of being sane. That is when a person is now in that realm of psychosis or symptoms of being psychotic. Then you have here neurosis. Here, this is where a person is going through a lot of problems, but is still maintaining a level of sanity. This is where depression, anxiety, phobias, panic, and other things similar to it, like OCD and PTSD and all other things, can fall under neurosis, where a person is going through so many different problems, but they're still maintaining a level of sanity. Whereas the insanity, losing that level of sanity, that is more on the psychosis side. So first, I wanted to get you guys to understand the differentiation between those two. Now, what I'm trying to say is that there wasn't a lot of funding. So there was a lot going on, and there was this push for training people in cognitive behavioral therapy to deliver treatment and support for people with common mental health problems at different levels, different severities and stages. Meaning what? You've got a person who has, let's say, can go through times where they're up and down. So feelings of low mood, that can be normal. Feelings of anxiety and worry, that can be normal. You fear that you've got a deadline next week. You have that fear. All of a sudden, some days you just feel low, maybe because you got out of the wrong side of the bed, whatever the case. But then it can go from that to mild, to moderate, then to severe. So who can deal with people from a mild to moderate sort of severity? So we're looking at mild to moderate severity, training people to deal with that area over here. Then training people to deal with people from moderate to severity. And then as severity escalates, as it gets worse, then it goes up high to more specialists, people who are more specialized to deal with those particular conditions and cases. The PWP, just to kind of get you to understand that since then, 2006, 2007, there's been a lot of talks, and it's been put forward to the government, to the House of Commons, to the House of Lords, and lo and behold, here we have fully a funded new program called Improved Access for Psychological Therapies, and this is kind of dealing things from a mild to moderate and moderate to severe sort of severity, to make sure that things are, people are taken care of and they're being supported at those given levels. So the training would be the person who's trained from mild to moderate, which I'll get to soon, is being trained with these type of people. And if they can't deal with it, if the person is needed of stepping up, what we call, then they'll be referred or signposted. Then they will move to another sort of step. Maybe I can explain that in the next video about the step care model, and then so on and so forth, depending on the severity. Now, with regards to the PWP role, what do PWPs do? PWPs, to be very short, psychological well-being practitioner. We are trained to assess, support, and treat people who have common mental health problems, such as anxiety, depression, and stress, at a mild to moderate severity range. So we are giving them the ability to help them in their self-management of their recovery. All right. If you want me to go into more depth, firstly, you can always Google it, or you can just ask me. I can make another video for it. So that's about the PWP, supporting people from a mild to moderate sort of severity range on how they can develop how they can build self-management skills so that they can improve in their recovery. How can they find the best sort of building a toolkit to deal with their problems and develop coping mechanisms at that level. Then we looked at, what did I say after that? The issue of diagnosis. How do you diagnose someone? Do you really diagnose? There's a bit of a debate on that right now. And then the issue of diagnosis and talking to them about what they're experiencing, reflecting on their outcome measures. Upon, what happens is that a client will complete the questionnaires, the PHQ for low mood, the GAD-7, for example, for anxiety and excessive worry, or others, and look into, we have that discussion, we have that talk. Is that what they're feeling? Does that reflect how they actually feel? And we talk about, okay, this is the objective, and this is right here, we're discussing, we're understanding more in depth of what they're going through. And with all of that, having those skills to build that therapeutic alliance, those skills to build that warmth, that comfort within that session, knowing that they're heard and that someone is here to hear them, understand them, listen, and also without being judgmental, without criticizing, but focusing on what is the right outcome and what is the right treatment, what is the right support for you. And with all of that said, assessing a person's risk, their risk to themselves and their risk to others, so that things can be dealt with at a better manner, because when the risk is high, it becomes a big issue. And we need to make sure that everyone, themselves and those around them, are safe. So that's pretty much of week 1. Join me for week 2.